I'm pretty hungry myself too, so I'll try to keep it a little shorter than what I had planned, but hopefully I'll get the message through. First of all, I would like to thank the organizers for inviting me. It's a great pleasure to be here. Okay, so I'm going to talk about diagnosing spine pathology using medical image analysis. My colleagues before talked about image analysis, so thank you for the introduction to that. And just some disclosures. What I'm presenting today is totally my opinion and nothing to do with the US government. Okay, so why lumbar diagnostics? I know a lot of you are pretty young here, but if I can have a show of hands of how many of you have ever had any back pain? Come on, the old guys. You're beating my statistics here. So the kind of back pains people have, I don't know if you can actually see the image from that far off, but the intervertebral disc there, that's what cushions you have a few different types of problems there. The most common one is what's called herniated disc. Right? More than 90% of the issues that happen are with herniated disc. And what that really means is the disc bulges out to a point where and you might actually have herniation, and probably most of us above 40 have herniation, but you may not feel the pain. You feel the pain when it actually hits the nerve points. So this is an acute problem, right? So I'll give you some statistics, and that's why I was trying to match what that statistics is here. Well, in US and perhaps in the world, it is the second most common disorder after headache. Okay. And 50% of Americans report back pain every year. Okay. So that's about 11 million Americans have been diagnosed with IDD, which is the intervertebral disc degeneration. So in about, I think in 2009, there were 30 million MRIs done in US every year. Of that, 50 million were for lower back. Okay. And if you are less than 45, this is the single biggest cause of activity limitations of all people. And when I was trying to get the statistics, 80% of people will actually go to visit a doctor because of lower back pain. I think I saw probably less than 10%. So either you guys are lying or you are totally off the charts. What's more interesting is over $100 billion are spent annually on lower back pain. But if you look at the research funding for lower back pain or spinal issues, that's a small fraction of all the funding that the NIH does. So you might wonder why that is. And the reason is that people actually don't really die because of low back pain. Right? With cancer, people die. And so NIH and the government is more interested in fixing that. But the economic impact of lower back pain is higher than any of the other diseases. Okay. What's also interesting and what got me into this game really was about in 2006 is the amount of medical fraud that happens in lower back pain exceeds $20 billion a year. Okay? And the kind of medical fraud that happens, and nowadays it's actually quite popular, is pain drugs, right? But actually what it started as was really over subscribing the surgeries. So you have a spine problem, you go and the surgeon says, well, I'll cut you open and fix it. And in most cases, it does not work well. Apologies to any spinal surgeons here. We have enough data to support that, but that was really what got us interested. So it's the economic impact of low back pain, and there's very little funded work on this. So let me get into a little bit more on the details. So what are the challenges in trying to do this automatically? So just a preview, over the last 12 years, we've worked on this problem, several PhD students. We've actually also started a company trying to commercialize this. We were able to get it to a point where the automatic system is going to be as good as a radiologist in detecting that you have any of these problems. Okay. But trying to get it in the commercial world is not easy, especially in US, because you have to go through all the FDA regulations, and that requires some deep pockets. So some of the challenges, and these challenges are not just for spine, these are challenges typically for most image analysis, particularly for medical image analysis. You have intensity inhomogeneity, and that's because you might actually be using different types of MRI machines. And you also have issues where two different organs might actually look the same in an MRI. Right? So MRI is not really true image. Right? If you want a true image, you want to get CT or an X-ray. And there's also this partial volume effect. All this sort of makes it very hard to isolate one portion of the image from the other. So over the years, we've worked on this lumbar CAD framework, and I'm actually not going to go into the details, but we were trying to diagnose one problem after the other. There are almost 80 different problems you can have in your lower back. And so we went on isolating or detecting each of those one by one. And what we realized was, hey, instead of doing this in a very ad hoc manner, there's actually some framework by which you can actually do this. So we proposed this quite a few years ago. And so what I will talk about, given the paucity of time, is I will talk about two problems. The first one is disc localization and labeling. And why do you need disc labeling? So I'm going to focus mostly on the lower lumbar. There are 6 vertebrae there, and you're looking at the discs in between. That's where you have most of your problem. The middle back is usually less problematic, and then you have some problem in your neck. So if you have to diagnose, you have to isolate where the problem is. So if you have 6 or 7 discs in your MRI image, you need to be able to label them, hey, this is L1, L2, right? So between L1 and L2, the 2 vertebrae, the disc, that's where the problem is. So you first need to localize that. So we use clinical data for this. In clinical data, getting access to that is usually not very easy. Most researchers will use research data, which is a little easier to deal with because that's not what you use in the real world. So we had 105 cases, 25 normal and 80 abnormal cases. This was a 3 Tesla Philips scanner. The images are 512 by 512, and that gives you a distribution of how many normal and abnormal discs there were. This is how a real radiologist report looks like. So, for example, in the top findings, it says at the L5S1. So L5S1 is the lowest most area, and that's where we actually have the most problems. Absolutely low back. There is a 5 millimeter broad right paracentral disc herniation. Okay, and then it says the L4, L5, L3, L4, and so on are normal. No fracture, and so on. That's how a real report looks like. And if you look at reports from different radiologists, they will all be looking differently even though they present the same thing. What was even more interesting was If you take your MRI to the same radiologist a day later, he'll be off by 50%. You take it to a different radiologist to get a second opinion, they'll be off by 50% as well. Okay? So that's a huge problem, right? So it also leads to issues when you try to come up with a technique and you try to verify how good is your solution. So the typical sense of precision and recall don't make sense here, right? Because I'm just trying to compare myself with a radiologist who's probably not right, or he doesn't agree with what the other radiologist thinks of. So you almost have to come up with what you might call similar to a Turing test, right? If you cannot identify whether this is the computer or a real radiologist, then you're fine. So the typical metric that is used for that is the kappa test, right? So you come up with that value, and for a value higher than a certain amount, you can safely assume you can't distinguish whether it's a real radiologist or it's the computer. Okay, so let me give a very high-level sense of the model for the labeling, and this was done fairly early on. So you have at the top level, you have 6 discs. So those are the lower lumbar level. And at the lowest level, you have an intensity-based model where it is the intensity of each pixel of the image. And then we introduce some of these phantom nodes, and that is actually going to help you mediate between the high level and the intensity level. You don't want to work totally at the intensity level, it becomes too hard. So the goal really is to maximize that function there for T. And the way it is right now, because of the intensity, it becomes intractable to do that. However, you can actually manipulate that, and the last equation that you have there, that actually makes it easy to be able to break down that problem into some smaller, simpler problems. Okay? And the model, here there are high level and low level aspects to that. And without worrying about the details of that, the top level is the intensity, right? So looking at your MRI image, if you see the intensity, that gives you a clue. For your discs, if the intensity is higher, that means you have more water, so you're potentially going to have a good disc. And then at the low level, there's also a spatial distribution, right? Your discs are typically oval shaped, right? So you should be able to figure in the model, you constrain that. And then at the high level, you have the location. And the location of the disc is also very relevant. They're not going to be just haphazardly placed, right? They all lie in a certain line. And there's also the context, that is how far apart are the discs. So you're not going to have 2 discs which are 3 millimeters apart and then one disc being 5 centimeters away. Right? So these are constraints that you can put, and then you can run this and you get your results. Interestingly, what we found was that the intensity variation was actually as shown there. It's a Gaussian model. Works out very well. It makes your math easier and your learning much easier. Right? That's sort of all the math I will talk about, but just to give you a sense of how this model works. So you can see the spatial distribution of those. Those are how the disk would typically be located, and you can put those constraints to figure that. I will skip these terms. And our group has done a lot of work on this. Let me see if I can show you. Yeah. So as far as we know, this was one of the first methods to automate the localization of disks, and this was 2009 to 2011 timeframe, before deep learning was really, in vogue because of the computing power. Then some of my other students took on this and they improved that. And what I'm going to do is I'm going to skip that, but it's a slightly different technique to come to the same conclusion. Okay. Okay. And I'm going to skip wedge compression also, but let me just pose the problem. So the first thing I talked about was using MRI images. If you actually have a fracture, MRI is not very good for that. So you would have to get a CT scan, or usually the first step is an X-ray. So here we actually looked at wedge compression. Because of the way your bones are, because you might have some other problems with your bone, because of compression there might be some fracture. And that's typically dealt with using CT images. So this is the problem of wedge compression fracture detection. At a high level, what you do is you try to segment each of the vertebrae, and you contour. You can see on the right hand side, that's how the different vertebrae are shown. And then to show that there is actually a compression, you come up with some features. These are very simple features, right? You look at the distance between the top and the bottom of each, and you see if there's a variation which is beyond the norm, right? And you use those features to do the learning. Okay. So that's how that was done. And you can see at the bottom there, the accuracy. Now this is a little easier to detect by the radiologist. From a CT scan to see a fracture is a little different than trying to figure you have a herniation, which is much harder, or the variation is much harder. So here the accuracy was about 94%. Okay, so after working a lot of years on trying to detect that there is a problem, we started working with some chiropractors. And the goal here was, hey, what's the point just detecting if you can't actually affect the change? Now what chiropractors do is, once you have a problem, they are going to apply some biomechanical forces and they're going to fix that problem. So they typically look at the curvature, which puts undue pressures on your spine, and they try to fix that. So that is the problem that we actually started working on. The problem that they have, of course, is it takes a very long time for them to actually do that, because they have to calculate. That's a warning for me to wrap up soon. So you have to do a lot of manual computations on detecting certain points in the spine, and then they compute the forces to do that. So our goal was really to take away the manual computation of that, and the points that they detect actually are the edge points of each of the vertebrae. Okay. Let me see if I can actually show you the results. Okay, I don't know if you can actually see that there on the iteration 1 image. You might see at the corners of the vertebra there red dots. Okay, those are the dots that the person has to manually put there, and we have to automate this process. Okay. And I will skip through the way this was done. One of the techniques gave 0.75 true positives, and then going forward, the way we are doing these things are trying to apply deep learning to this. The problem with deep learning, it's been very successful with typical images, is it requires tremendous amount of data to learn, right? It's very easy to get images of cats and dogs on the internet. You can get a few million of those and you can learn. Medical images are very hard to get, right? And especially if you want labeled data. And especially if you have to go through the official means of privacy and taking care of those HIPAA regulations. So how do you apply deep learning to use all the benefits of deep learning, but from a very small data set. So that was what we actually focused on in this. And what I will very briefly share is, this is the typical disk detection or typical image analysis kind of scenario. You have some sliding window type of algorithms, and then you have some handcrafted features. There's some popular ones I list there, and then you may have an SVM or some sort of neural network after. So what we did was, instead of using those handcrafted features, we used a pre-trained CNN. Right there. So you have a CNN which has been trained using cats and dogs. And I use those, extract features from there, and then use the classifier. So as an example, we used CafeNet, that's trained on 1.2 million images, and we actually trained it using 15 images of the medical images. And we looked at training based on those features. And you can see the overall accuracy, that's the last column. You have 0.97 accuracy. So that is one way of doing that. And we further explored that So we proposed a new method called spined RCNN. And here we've taken typical RCNN and customized that for the spine. And in this case, we looked at over 1,000 clinical lateral X-ray images. Now these are X-ray images. So I showed you MRI, CT, and the X-ray images. And those are the testing and training. Let me see. So we compared this. So there's a lot of work done on this for typical human pose type of thing. So CVPR 2017, there were a couple of papers, and so we applied those techniques, and that's the comparison. At the bottom is our technique, about 95% accurate. Okay. Again, sorry you can't see this. Those were images showing you how complex actually getting those points is. And with that, this is some of the current work that we are doing. Now, more and more people are starting to use clinically as well, but very limited amount, 3D MRI. So applying 3D MRI, and of course, trying to apply deep learning to almost everything. So some of the previous work that I showed you took a PhD student a couple of years to do. If I give that problem today to a master's student as a class project, he will have better outcomes than that one. That's how fast things have progressed. So certainly the expectation of doing that. And then we are also looking at how can we have a business model to try and make this available to real clinicians. Okay. With that, thank you for your attention. I'll be happy to take any questions if someone has.
Thank you very much, Professor, for that. Can we give him a round of applause, please? I think I'm going to ask, in the essence of time, that since your baseline study prior to the start of your talk indicated that the younger generation are still to discover that they're going to develop these back problems. So the other people here who will be with you at lunch, maybe if they have some burning questions, that they could address those with you over lunch, and then you can at least enlighten them. The younger lot will learn that from sitting slouching in your chairs, that is the posture problem that you will develop in time to come.
Right, so, and you may not feel the pain in your back, you might feel it in your legs.
There we
because
go.
of the back.
So thank you once again, a very, very interesting and insightful presentation presented by you. Thank you.